My name is Teresa and I'm going to talk about methylphenidate and brain development. Here are my learning objectives. To summarize the epidemiology of attention deficit hyperactivity disorder (ADHD), to present current treatment options for ADHD, to evaluate clinical studies for the effects of methylphenidate on the development of human brain white matter. ADHD is one of the most common neurobehavioral disorders in pediatrics. In 2016, about 9.4% of children from 2 to 17 years of age have ADHD. The majority of children with ADHD are from 2 to 17 years old. Out of children with ADHD, 77% of them receive treatment, with 30% treated with medication alone. About 15% receive behavioral treatment alone, and about 32% received medication plus behavioral therapy. In 2016, more children with ADHD receive medication compared to behavioral therapy alone, 62% versus 47% respectively. Much more children from 2 to 5 years old receive behavioral therapy than ADHD medication. In contrast, more children from 6 to 17 years old receive ADHD than behavioral therapy. This is the pattern of state-based ADHD medication and behavioral therapy in children with ADHD from 4 to 17 years old. Medications are commonly prescribed for children with ADHD in the Midwest and Southwest areas. Behavioral therapy is commonly used in the Northeast area and in Oregon, California, and Hawaii. In Texas, behavioral therapy is not very common, and medication is more common with 70 to 76% of children. If untreated, patients are more likely to experience long-term consequences of ADHD. For example, substance alcohol abuse, criminal activity, poor academic achievement, and job performance. It is very important to recognize ADHD and treat it to prevent functional impairment using medications, behavioral therapy, or both. Management of ADHD is recommended based on age. For children from 3 to 5 years of age, behavioral therapy is the first-line treatment. Methylphenidate may be considered if behavioral interventions do not provide significant improvement. For children older than 5 years old, stimulants are recommended as first line. Behavioral therapy in combination with medications is preferred. Non-stimulants can be used as monotherapy in patients who fail stimulants, or can be added to stimulants in patients who cannot tolerate high dose of stimulants or cannot achieve optimal benefits from stimulants at maximal dose. Behavioral therapy is recommended with or without medication therapy. Behavioral therapy may be considered in children who do not meet ADHD diagnostic criteria. Studies show that behavioral therapy plus medications did not have significantly better efficacy compared to medication alone for the core symptoms of ADHD. But the combination may improve academic conduct measures, family-related outcomes better when children have both ADHD and anxiety, and they live in the low socio-economic environments. With the combination therapy, lower dose of stimulants may be used and thus may reduce the risk of adverse effects. For this topic, I'll focus on stimulants. Stimulants work by blocking norepinephrine transporter in prefrontal cortex and dopamine transporter in the nucleus accumbens, leading to increased synaptic norepinephrine and dopamine. The efficacy rate is pretty high, up to 90%. Stimulants are effective for both inattentive and hyperactive impulsive symptoms. Stimulants have black box warning for sudden death, stroke, and MI. They also have high risk of drug dependency and abuse. Common side effects include reduced appetite, weight loss, GI upset, insomnia. Some rare adverse effects that patients and families should be aware of are tics and abnormal movements, psychiatric symptoms, and growth suppression. As stimulants target the brain, there are some concerns that they might potentially change the brain development, especially in young children. I'm going to talk about a prospective randomized controlled trial that studied methylphenidate and human white matter development in boys and adult men with diagnosis of ADHD of all types. They have not received stimulants before this study. There were 50 boys from 10 to 12 years old and 48 adult men from 23 to 40 years old. They were randomized to receive methylphenidate or placebo for 16 weeks. The children and the adult groups did not differ significantly in age, ADHD symptom severity, and the adherence is pretty high across the groups. They performed diffusion tensor MRI 1 week before treatment initiation and 1 week after treatment discontinuation. The primary outcome was the change in fractional anisotropy. They did 2 types of analysis, regions of interest analysis for 3 brain regions, whole brain, bilateral, anterior thalamic radiation, and corpus callosum. They also performed voxel-based analysis for whole brain white matter, and I'm going to go over some terminologies in a second. Diffusion tensor imaging is a non-invasive method that describes the white matter organization between the gray matter regions. It is an MRI modality that measures diffusional motion of water molecules, and by doing that, it evaluates microstructural features of white matter and microfiber pathways. The study looked at the white matter. The white matter underlies the gray matter cortex and is present over half of the human brain. It is composed of neural fibers coated with myelin. White matter is important for cognitive functions, information processing, and learning. Fractional anisotropy FA reflects direction of water diffusion along white fiber tracts and fiber density organization, also axonal diameter, and extent of myelination of the white matter. In cerebral spinal fluid, the FA is close to 1, while in corpus callosum, FA is around 1. Higher FA values suggest white matter pathology. FA is highly sensitive but not highly specific for white matter microstructural changes. Also, it is unknown that diffusion MR markers of white matter is associated with underlying tissue integrity. In this study, they used 2 methods to extract and analyze diffusion tensor imaging, region of interest, and voxel-based morphology. For region of interest analysis, it is done by drawing manually. This method has higher sensitivity to abnormalities in small and local structures, but doesn't have a valid protocol that may lead to potential subjectivity and user error. The voxel-based morphology is an objective and faster approach. It is computational and fully automatic with high regional specificity. After 16 weeks, they did not find three-way interaction between time, age, and methylphenidate across regions of interest. However, methylphenidate is associated with increased white matter FA in boys and with ADHD in voxel-based analysis. This is region of interest-based analysis. These are scatter plots of changes in raw FA in whole brain, anterior thalamic radiation, and splenium. Below are the box and whiskey plots showing marginal means of change in FA. As you also notice, across the groups, there is no difference in FA. This is voxel-based analysis in adult men with ADHD, and in both boys and adult men receiving placebo, changes in FA measures were not present, suggesting that the effects of methylphenidate on brain white matter are affected by age. In conclusion, further research is needed to explain clinical correlation of FA findings in children with ADHD receiving stimulants, and to include the female population. Currently, there is lack of evidence of FA findings with methylphenidate may have potential impact on long-term behavioral changes. And it is always important to prevent misdiagnosis of ADHD and overprescribing ADHD medications due to high risk of controlled substance abuse and drug adverse effects. Non-pharmacologic interventions should be encouraged and discussed with the patients. Pharmacists play a role in optimal medication management of ADHD and addressing medication-related concerns or issues, thus improving patient adherence. Pharmacy can also provide patients with evidence-based information about medications and encourage them to seek help from healthcare providers. And here are my references. I hope you enjoy this topic. Thank you.